Okay, everybody good with my slides? So I'm Brigid Miller. I'm a graduate student in marriage and family therapy at Northwestern University. And today I'm going to talk about the other face of autism, addressing the needs of adolescent girls in diagnosis, treatment, and support. So today I'm going to start with a story. We'll talk about definitions and prevalence. We'll talk about diagnostic challenges with respect to girls, social functioning issues unique to girls, treatment, both individual and family therapy models, and then a discussion of where we go from here. And then I'd love to hear from all of you. So first, I want to introduce you to Nora. Nora was diagnosed with autism when she was 9 years old after exhibiting social and emotional delays that her parents were told was the result of ADHD and anxiety. Highly extroverted and verbal, she successfully masked her symptoms until the clear differences with her peers began to emerge in school. Nora's restricted interests include Disney, as you can see, and Broadway musical theater. She's a talented actress and podcaster. She's also my daughter. So I bring you this as a graduate student and as a mother. 1 second, please. So ASD is generally identified through deficits in areas of social communication and restrictive repetitive patterns of behavior. Just a brief history, in 2013, I'm going to change my view here. Sorry. In 2013, the DSM-5 consolidated what used to be separate categories of symptoms under just one umbrella diagnosis of autism spectrum disorder. And then just this spring, the DSM-5 TR was released, which adjusted the wording to specify that all of the following must be present: deficits in social emotional reciprocity, nonverbal communicative skills, and developing and understanding relationships. Many in the autism community use graphics such as this one to show how autism is not a linear spectrum, but rather more of a pie chart. An individual can have strengths or deficits in any number of combinations within the categories. Thus, the spectrum is highly individual. Someone doesn't have more or less autism. As we'll discuss today, girls often present with different autism symptoms that are missed by teachers, mental health practitioners, pediatricians, and others. If these symptoms are missed, it means lost opportunity for early intervention for these girls and their parents, which can have long-term effects. According to 2016 data, ASD prevalence was about 1 in 54 children at age 8 in the United States, and ASD was about 4.3 times as prevalent in boys as girls. However, one look at 54 different studies found the true male to female ratio is probably closer to 3 to 1, and that there appears to be what the authors called a diagnostic gender bias, meaning that girls who meet criteria for ASD are at disproportionate risk of not getting a proper diagnosis. Prevalence is also lower among Black and Latinx children, meaning these children could also be missed more frequently than white children. So often the discussion of autism focuses on North America and Western Europe, but when we look internationally, the highest rates of autism and the greatest number of cases are located in some of the countries with very few resources or services for these children. An important aspect of ASD presentation in girls is the concept of masking or camouflaging. A girl who may have higher verbal or executive function skills is able to camouflage her true symptoms through imitation and conversation skills. And while this may work for a while, it exerts a tremendous toll on these girls. The effort required to mask their true abilities and consistently imitate the world around them has been shown to lead to increased rates of anxiety, stress, and depression among girls with ASD. Children with higher cognitive ability, verbal skills, and executive function, again, features typical in female autism presentation, are thought to be able to mask effectively, and therefore they elude early diagnosis until school and those social demands increase. But this is damaging in the long term for so many reasons, particularly because we know early intervention works. And in particular, children with milder symptoms and less cognitive disability are likely to see significant change with early treatment. We're more likely also to see adolescent girls with ASD presenting later with internalizing disorders such as OCD, eating disorders, and anxiety as a result of not only masking who they really are, but also because of the isolation that can come from being different than their peers. Another serious risk for later diagnosed women is physical, emotional, and sexual abuse, potentially because of their challenges understanding social cues, recognizing risky situations, and again, isolation from peers. Sexual victimization in adolescent girls and adult women could also be the result of lower levels of sexual education. We know that adolescents with ASD frequently experience bullying, and one study showed the effects of specific types of bullying were different for girls and boys. They report more bullying related to friendships and social relationships, with girls being particularly vulnerable to those relational bullying because of the complexities of female adolescent friendships. Girls with challenges such as understanding sarcasm or reading social cues can find it difficult to imitate these behaviors. These quotes really illuminate how some of these women feel after being diagnosed later in life. In particular, this study found what they called a shockingly high incidence of sexual assault in their sample. A few of the reasons they cited were that these girls or women tended to imitate actions like male flirting, or they had difficulty reading whether a person was being friendly or creepy, as they put it. Since they may not have as many friends, they lack a reference point for developing safety strategies. They experience rejection that leaves them feeling desperate for acceptance and more vulnerable to exploitation, or they could have a lesser understanding of social rules or the idea that they could say no to sexual advances. Now let's look at treatment. Treatment for ASD should ideally consist of what we call a three-legged stool, including behavioral interventions, medical support from physicians or psychiatrists as warranted, and emotional support for families. Particularly for girls, as we said, addressing the sense of shame, depression, and anxiety is key. As we know, autism takes a tremendous toll on the family. Parents, in particular of girls, will report years of trying to fix their daughter. They blame themselves. They didn't realize what the symptoms looked like. There's often shame, and there's often a lot of parental conflict. There can be fear and confusion when they do get the diagnosis. So parents and siblings really need to be supported on their own journeys. We know the benefits of family therapy, and research has shown numerous family therapy models to be helpful in addressing the needs of these families. But perhaps most important is psychoeducation for parents, allowing them to feel empowered and effective and to decrease their shame and their fear will all benefit the child and others in their system. So let's look at the limitations of research. One result of girls' symptoms being missed is that boys are obviously more likely to get an autism diagnosis, which in turn leads to boys being overrepresented in the research. Our body of knowledge as a whole remains focused predominantly on the symptom presentation in boys. And this leads then to gaps in evidence around diagnosis, symptom descriptions, treatment specifications, all that consider girls' specific needs. In addition, girls and their families continue to feel isolated and frustrated. They may be told that they have certain conditions, seek treatment for those, and get limited results. The girl herself will undoubtedly know that she's different, but without a clear understanding of the way her own mind works, she's likely to continue to feel confused. And finally, therapists need to understand camouflaging and understand what this does to shame and exhaustion and identity confusion. So where do we go from here? We need to look at holistic training from all of these professionals that might interact with these families. In particular, we need to make sure the right girls are funneled into neuropsych testing. Currently, most graduate level therapy and counseling programs don't include autism in their curriculum. So we can do more to equip clinicians to make sure they're able to help families. Finally, as we know, many of these professions don't always talk to each other, so we can work toward an integrated standard of care for these girls. In addition to integration, more attention to the biopsychosocial developmental needs of girls in particular. For example, with respect to menstrual care, one study looked at helping parents teach those skills in ways that will be more effective with girls with autism. Another study looked at sex education and found that helping parents facilitate the conversations with skills-based strategies can be effective. And we know this is so important as higher levels of exploitation, as we discussed, have been tied to sexual ignorance in this population. And finally, culturally informed care is critical. One study that looked at adapting autism transition programs to Spanish-speaking families noted that more multifamily group interventions are needed, and this will be particularly important for girls and their families to build community. So the future, there are important questions about the ways families access care and understanding the barriers that exist to treatment. Where does the family turn if the school and the pediatrician did not see this girl's symptoms and are not making proper referrals? How can we make sure ASD treatment is not another benefit of privilege? How can we make sure that treatment is available for those who can't afford it, especially with respect to neuropsych testing, which can be expensive and difficult to obtain? What do therapists and others need to understand about cultural barriers? When they see a girl presenting with symptoms, but a family who's very resistant to the idea, how can they work to understand what those resistances is about and help that family? Only now will there be a large pool of older women who are diagnosed with ASD during childhood. So research can better help us understand the needs of the female throughout her lifetime. And not to mention the role of hormones, changing hormones, the aging brain, all of these things will be important to understand. Finally, there's a clear demand for more empirical research, looking at family therapy, looking at all different types of female presentation. The gap between research and clinical practice highlights the need for professional organizations such as the AAMFT, which is Marriage and Family Therapists that I'm a part of, to make ongoing continuing education units available. Schools can do the same, so the teachers understand the needs. For example, in many public schools, you can find social skills groups for boys, but they're far less common for girls. And we know that girls need their own group. Their symptoms, strengths, and experiences are different, and they can build support and help each other through this journey. With that, I thank you so much for your interest in this topic, and I'd love to answer your questions, hear about your experiences, and here's my contact information as well.